Let's start with a new unit of pathology, that is renal pathology. Here, in this unit, we'll be learning about kidney and urinary tract disorders. The first thing in this chapter would be histology of the kidney. We must know about histology of kidney to go further. Here figure में we can see the components of nephron, starting with the glomerulus, which is the tuft of capillary, as you can see here. It is known as glomerulus. It is formed by efferent arteriole, which enters the Bowman's capsule, and the efferent arteriole. उसके बाद फिर PCT आता है. Proximal convoluted tubules further continue करता है as loop of Henle. Loop of Henle का 2 part होता है. There is thin descending part and then there is thick ascending part. उसके आगे you will see distal convoluted tubule and बहुत सारे DCTs जा करके एक duct में drain करते हैं, which is known as the collecting duct. So one by one we'll talk about a bit about glomerulus and each of the components. First being the glomerulus. It is the basic filtering unit of kidney. It consists of tuft of anastomosizing network of capillaries. As you can see, it consists of tuft of capillaries, and these capillaries, they are lined by fenestrated endothelium, which lie on the glomerular basement membrane. The outer surface of the glomerular basement membrane, it is covered by visceral epithelium, which is otherwise also known as podocyte, and they have food processes, which are known as pedicles. So the capillaries, they are lined by fenestrated. What do you mean by fenestrated endothelium? Actually, these epithelium, they have slit-like opening in between them. This is why it is known as fenestrated endothelium. Has sieve-like appearance or window-like openings. They lie on the glomerular basement membrane. The outer portion of the fenestrated endothelium is the cell. They are in contact with the outer portion of fenestrated endothelium cell, they are in contact with the inner surface of glomerular basement membrane, whereas the central part, it is in contact with mesangial cell or the mesangial matrix. The entire outer surface of glomerular basement membrane, it is covered by visceral epithelial cell, which are known as podocyte food processes. The visceral epithelial cell, they line the glomerular side of Bowman's space, whereas the epithelial cell line the Bowman's capsule of the opposite side. So in this figure, I have drawn a figure here. This is the tuft of capillary here we can see, which we call the glomerulus, but the outer part, it is known as Bowman's capsule. This part which we are seeing here is not the part of glomerulus, but it is the part of Bowman's capsule, and the cell lining these, which is the parietal epithelial cell, are the cell of Bowman's capsule. ये हमारा glomerulus है. Glomerulus को जो line करता है epithelium, this epithelium is visceral epithelial cell. This is the cell we also call it podocytes. They have food processes present in between them, which is known as pedicles, and in between them you'll find some of the mesangial cells. And outer surface mein, as this is the Bowman's capsule, apart from this, here you'll find the cell of Bowman's capsule. I hope this is clear. Now about loop of Henle, I'll just state some of the highlighting points about loop of Henle. The PCT, it drains straight into the loop of Henle. About PCT, it is lined by cuboidal epithelium. Cuboidal epithelial cell with brush border. Cuboidal epithelial cell with brush border. These are the cell of PCTs are lined by this, and the function is active reabsorption. Coming to loop of Henle, the PCT it drains straight into the part of loop of Henle, consists of thin and thick, as I said earlier. The descending part, it is lined by the descending part is lined by simple epithelium, whereas the ascending part is lined by columnar cell. So it is cuboidal epithelium, simple epithelium, and columnar cells. Columnar epithelium, you can say. And further, here also the active reabsorption of sodium, potassium, and chloride takes place, whereas there is passive reabsorption of water as well. The DCT, it is lined by cuboidal cell. I hope you can appreciate the variation here and not confuse between them. जो collecting duct है, they are also lined by cuboidal cell, but they are without brush border. Now, जो हमारा main topic था, that is kidney and urinary tract disorder. Now that we are clear about histology of kidney, let's start about the glomerular disease. Classification. How will we classify glomerular disease? They are basically divided into primary glomerulonephritis, or also known as glomerulopathy, and then there are secondary glomerular disease. Primary वो है in which the kidney is the only predominant organ involved. Like primary disease में the other organ like liver, lung, heart, they are not primarily involved, or they are not predominantly involved. Those diseases are known as primary glomerulonephritis. So some of the examples of primary glomerulonephritis are acute proliferative glomerulonephritis, rapid progressive glomerulonephritis or RPGN, there is minimal change disease MCD, membranous glomerulonephritis MGN, there is membranoproliferative glomerulonephritis, focal segmental glomerulonephritis FSGN, IgA nephropathy or chronic glomerulonephritis. These are some of the disease which we'll read further in the chapter, so don't just worry about them. Just get familiar with the name. Now, looking into the secondary glomerular disease, these are disease where the glomeruli are involved secondary to the systemic disease. It's like the primary disease is in some other organ, like it can be heart, it can be lung, it can be liver, any other organ, blood vessels or anywhere, but the glomeruli are affected due to that organ, that disease in the other organ. Some of the examples are systemic immunological disease like SLE, systemic lupus erythematosus, metabolic diseases like diabetes mellitus, vasculitis, deposition diseases like amyloidosis, Good's pasture disease, Good's pasture syndrome, or bacterial endocarditis. These are just some of the examples. The glomerular disease can also be hereditary, like Alport syndrome, thin basement membrane disease. Now, there are some terms which you're gonna hear again and again in this chapter. Let's know what they are. Diffuse or generalized means that all the glomeruli which are present in one kidney or both the kidney are affected. यहाँ पे हम लोग नंबर के टर्म से मीन कर रहे हैं डिफ्यूज और जनरलाइज. लाइक सपोज देयर 100 glomeruli in one kidney and all the 100 of them are affected, then you'll call it diffuse or generalized. The second term is focal, where it affects only a portion of glomeruli and not all. Focal means out of 100, only 50 of them are affected, which means, as you can see, not all of them are affected, but only a portion of them are affected, so it's called focal. The third is global. Now, here we'll be talking about individual glomeruli. Global मतलब एक glomeruli पूरा entirely diseased हो, like entirely the whole glomeruli is affected, then you'll call it global. Segmental, जब भी इस glomeruli का, sorry for this bad diagram, इस glomeruli का कोई एक part, suppose this is the only part which is affected, we'll call it segmental. And mesangial और capillary, इसमें mesangial region और capillary primarily involved होता है. So I hope you're clear with these terms. Diffuse, all of the glomeruli affected, like 100%. Focal, only a portion, mostly 50%. Whole of the individual glomeruli is affected. Segmental is part of glomeruli affected. Mesangial or capillary lobe is affected करता है predominantly mesangial region of the capillary. Now let's see what are the histological alteration which we'll see in glomerular nephritis. The three basic histological changes are seen. First, the cellularity may increase. That is, glomerulus will be hypercellular. First change is hypercellularity. Second is thickening of basement membrane. Third is hyalinization or sclerosis. एक एक करके we'll learn about them. Hypercellularity, which means increase in cellularity. We all know that. ये होता कैसे actually? So there is increase in number of cell in a glomerular tuft. Cell के number में increase होने के कारण you'll see hypercellularity. Acid lesions को we call proliferative glomerular nephritis, क्योंकि it's very clear that the cells are proliferating and they're increasing in number, so the name. Now, what may be the reasons? First, it can be cellular proliferation, uncontrolled kind of proliferation of cells. Second, it can be leukocyte infiltrations, blood vessels से leukocyte infiltrate कर जाए तो. Third can be formation of crescent. We'll learn about this further. Just remember here for now, it is the proliferation of parietal epithelium and infiltration of leukocyte which lead to formation of crescent. तो ये three reasons, cellular proliferation, leukocyte infiltration and formation of crescent, they may lead to hypercellularity. This was the first histological change. The second histological change being basement membrane thickening. What's the reason behind it? It may be due to deposition of immune complex or electron dense material. Immune complex, as you may know, the antigen antibody complex and all, ये सारे के deposition या फिर इलेक्ट्रॉन डेंस मटेरियल के डिपोजिशन के कारण बेसमेंट मेम्ब्रेन थिकन कर जा सकता है. Then there can be thickening of basement membrane in general also in diabetic glomerulosclerosis. These are the two reasons for basement membrane thickening. Third histological change been hyalinosis and sclerosis, or also we can say that hyalinization and sclerosis. These two are separate terms. First, let's see what is hyalinosis. It is accumulation of homogeneous and eosinophilic material in glomeruli. Homogeneous material and eosinophilic materials like eosinophil also in glomeruli. ये कंसिस्ट करता है प्लाज्मा प्रोटीन का जो कि लीक हो जाता है फ्रॉम द सर्कुलेशन इनटू द ग्लोमेरुलर कैपिलरीज. सेकेंड venous sclerosis, it is accumulation of extracellular collagenous material either in the mesangium or capillary loop or both. So this is sclerosis. So you can see the difference. I hope here in hyalinosis there is eosinophilic material, homogeneous material like plasma protein in glomeruli, but in sclerosis there is extracellular collagenous material like it can be collagen fibers and all in the mesangium or capillary. So this is of. Now let's see the pathogenesis of glomerular injury. हम लोग डिजीज के बारे में तो पढ़ लिए. We have also learned about the histological changes here. अभी पैथोजेनेसिस क्या है वो देखते हैं. सो देर आर टू मेन मैकेनिज्म जो कि हम लोग देखने वाले हैं. फर्स्ट ऑफ देम इज इम्यूनोलॉजिक एंड द अदर वन इज नॉन इम्यूनोलॉजिक. इम्यूनोलॉजिक मैकेनिज्म में फर्स्ट आता है एंटीबॉडी मेडिएटेड इम्यूनिटी. सो एंटीबॉडी मेडिएटेड इम्यूनिटी, इसमें द one of the reason it can be circulating antigen antibody complex glomerular nephritis. It is caused due to trapping of circulating antigen and antibody complex within the glomeruli. So type 3 hypersensitivity reaction के कारण they can accumulate within the glomeruli, and this antigen may be exogenous or endogenous. Exogenous है तो it can be due to any autoimmune disorder like SLE, and exogenous can be seen in microbial antigen, spirochetal, parasite, tumor antigen. These antigen they form complex with antibody and they can accumulate in the glomeruli, leading to this immunologic mechanism. It can also be due to injury by activating complement and recruiting leukocyte. The deposited antigen complex in the glomeruli ये प्रोड्यूस करता है इंजरी बाय एक्टिवेटिंग कॉम्प्लीमेंट एंड रिक्रूटिंग लिकोसाइट. सो फर्स्ट तो टाइप 3 हाइपर सेंसिटिविटी रिएक्शन के कारण या तो एंडोजेनस और एक्सोजेनस रीजन्स ये एंटीजन एंटीबॉडी ये ट्रैप हो जा रहा है हमारे ग्लोमेरुलाई में. फर्दर ये कॉम्प्लेक्सेस ये इंजरी प्रोड्यूस करता है by activating complement and recruiting leukocytes. You are familiar with the complement system and the complements like cytokines and all, और leukocyte को recruit करके they actually initiate the process of injury to the glomerulus. They may be found in any of the sites like mesenterium, subendothelium or subepithelium as well. The second reason here is in situ antibody. In situ antibody, these are the fixed glomerular antigen. So here in situ antibody is like antibody is produced against our own glomerular basement membrane. These can also lead to immune mediated reaction and cause injury to the glomerulus. So it can be seen in like anti-glomerular basement membrane antibody glomerular nephritis, or it can be antibody which directly react with intrinsic or fixed antigen of the glomerular basement membrane proper. The second reason it can be in situ antibody which is against planted antigen. Some antigen they may not be normally present in the glomerulus but they are planted to the glomerulus. This planted antigen include nucleosomal complex, which is mainly derived from breakdown of apoptotic cell, bacterial products and large aggregated protein. So कुछ antibodies जो कि normally glomerulus में present होते नहीं है but they are planted, and ये plantation का process nucleosomal complex इंक्लूड करता है. ये derive हो सकता है apoptotic cell के breakdown से, bacterial product के breakdown से और large aggregated protein. ये सब के कारण they can be planted antibody. The third reason it can be by complement activation. Now this was about the antigen mediated reaction. जो second reason हो सकता है immunologic mechanism का, it can be cell mediated immunity जहाँ पे type 4 hypersensitivity reaction देखने के लिए मिलता है, और it can be secondary pathogenic mechanism like neutrophilic infiltration and all. So this was about immunologic mechanism. जो दूसरा mechanism है as I told you, it is non-immunologic mechanism. मतलब यहाँ पे कोई एंटीजन एंटीबॉडी कॉम्प्लेक्स इन्वॉल्व नहीं होता है. नॉन इम्यूनोलॉजिक ये एक तरह से सेकेंडरी रीजंस भी हो सकता है. दी फर्स्ट ऑफ देम और सम ऑफ देम आर लाइक मेटाबॉलिक ग्लोमेरुलर इंजरी जैसे कि डायबिटिक नेफ्रोपैथी, हीमोडायनेमिक इंजरीज जैसे कि सिस्टमिक हाइपरटेंशन में देखने के लिए मिल सकता है, डिपोजिशन डिजीज़ लाइक एमाइलोइडोसिस, infectious disease like hepatitis B virus, C virus and HIV. Drugs like NSAIDs, they can also induce this kind of injury. Now so this was all about the pathogenesis. अगर एक बार फिर से देखें तो पैथोजेनेसिस का 2 मेन मैकेनिज्म है, इम्यूनोलॉजिक एंड नॉन इम्यूनोलॉजिक, सॉरी अबाउट द स्पेलिंग। सो ये 2 मैकेनिज्म है। इम्यूनोलॉजिक के अंदर देयर इज एंटीबॉडी मेडिएटेड या तो सर्कुलेटिंग हो सकता है या फिर इन सिटू हो सकता है। इन सिटू कैन बी फिक्स्ड एज वेल एज प्लांटेड, इट कैन बी प्लांटेड। एंड द सेकेंड इम्यूनोलॉजिक मैकेनिज्म के अंदर जो आ रहा है वो सेल मेडिएटेड हो सकता है, और ये सेकेंडरी पैथोजेनिक मैकेनिज्म जैसे कि न्यूट्रोफिल एक इन्फिल्ट्रेशन हो सकता है। जो नॉन इम्यूनोलॉजिक मैकेनिज्म है उसमें हमारा डायबिटिक नेफ्रोपैथी, सिस्टमिक हाइपरटेंशन, एमाइलोइडोसिस और ड्रग्स, इन्फेक्शियस डिजीज, ये सब हो सकता है। नाउ लेट्स सी इनटू द नेफ्रोटिक सिंड्रोम। व्हाट इज नेफ्रोटिक सिंड्रोम? It is the constellation of clinico-pathologic features which is characterized by the most important point being massive proteinuria. Proteinuria is the excretion of protein in more than normal amount in urine, that is more than 3.5 gram per day. This being the first characteristic feature. Second, hypoalbuminemia, less than 3 gram per deciliter albumin in the plasma. Third is generalized edema, and it also may be associated with increased serum lipiduria. Now let's look into the pathophysiology. सो जो डैमेज है हमारे ग्लोमेरुलर कैपिलरी वॉल को, ये इंक्रीज कर देता है देयर परमिएबिलिटी टू प्लाज्मा प्रोटीन। सो अगर दिस नेफ्रोटिक सिंड्रोम, ओके, सो डिजीज़ का क्या क्या रीज़न हो सकता है ये हम लोगों ने अभी पैथोलॉजी में देख लिया है, पैथोजेनेसिस में देख लिया है कि जो भी रीजंस हो सकते हैं डिजीज़ के। तो अल्टीमेटली ऑल ऑफ देम आर लीडिंग टू ग्लोमेरुलर इंजरी, राइट? Damage can lead to increase in its permeability, and most of the things तो glomerulus से filtrate हो जाते थे, right? But plasma protein जो कि पहले नहीं filter हो रहे थे अब वो भी filter हो रहे हैं, so there is its increased permeability to plasma protein. Obviously if there is increased permeability, so there is going to be more and more filtration leading to massive proteinuria. Major portion of the protein lost in the urine is albumin, will decrease leading to hypoalbuminemia, and hypoalbuminemia can lead to decrease in colloidal osmotic pressure of the blood. Albumin is one of the major factor for maintaining the colloidal osmotic pressure of blood. अगर albumin कम हो रहा है तो obviously there will be decrease in colloidal osmotic pressure of blood. This were the two features, and the third is the generalized edema. Generalized edema, what is the cause of edema? We have read it, or we have seen that already there is hyperalbuminemia, there is decreased colloidal osmotic pressure. This is one of the important reason for edema. Second, there can be accumulation of fluid in interstitial space leading to generalized edema. There can be sodium and water retention, जिसके कारण प्लाज्मा वॉल्यूम कम हो जाता है, GFR कम हो जाता है, and the compensatory mechanism, that is aldosterone secretion, increase हो जाता है. And you know very well aldosterone is responsible for sodium and water retention. Further, it will enhance the generalized edema, right? Now characteristic of this edema is that it is soft and pitting type of edema. ये periorbital region and dependent portion of body में ज़्यादा देखने के लिए मिलता है, और it is most marked in those regions. Now the fourth is hyperlipidemia. Reason, liver जो nephrotic syndrome है इसका stress is increased like 10 folds or more than that. Already there is increase in proteinuria, there is massive proteinuria going on, और रखा है albumin, we are losing albumin, and due to this loss liver is taxed with the stress of increased albumin production, and there is increased synthesis of lipoprotein. So albumin production का task liver पे बढ़ जा रहा है, liver has to produce more and more lipoprotein now, and it also lead to abnormal transport of circulating lipid and decreased catabolism of lipid, जो कि collectively cause करता है hyperlipidemia. अब ये एक फ्लो चार्ट है जिसमें वी कैन सी द पैथोजेनेसिस. Here you can see edema and lipiduria का mechanism very clear. So there is glomerular damage. Permeability of glomerular basement protein के लिए बढ़ जा रहा है. There is massive proteinuria more than 3.5 gram per day. There is hypoalbuminemia. All of these are related to each other. Okay, you can see कि डैमेज के कारण परमेबिलिटी में इंक्रीज है. परमेबिलिटी इंक्रीज करने के कारण देयर इज मैसिव प्रोटीनूरिया. प्रोटीनूरिया के कारण हाइपोएल्ब्यूमिनेमिया. प्लाज्मा में सीरम में एल्ब्यूमिन लेवल कम हो जा रहा है, लेस देन 3 ग्राम पर डे. इट कैन फर्दर लीड टू 2 things, not 2, 3 actually. edema in the first, then प्लाज्मा ऑन्कोटिक प्रेशर कम हो जा रहा है, प्लाज्मा वॉल्यूम कम हो रहा है, इसके कारण देयर इज डिक्रीज GFR. GFR कम होने के कारण द कंपनसेटरी मैकेनिज्म दैट इज देयर इज इंक्रीज सिक्रेशन ऑफ एल्डोस्टेरॉन विच लीड टू सोडियम एंड वाटर रिटेंशन. एंड द थर्ड थिंग जो कि ये कॉज कर रहा है, इट इज इंक्रीज सिंथेसिस ऑफ लाइपोप्रोटीन इन लिवर, एबनॉर्मल ट्रांसपोर्ट एंड ऑफ सर्कुलेटिंग लिपिड. ये सब के कारण कैटाबोलिज्म ऑफ लिपिड इंक्रीज कर जा रहा है, हाइपरलिपिडेमिया एंड फाइनली देयर इज लिपिडूरिया. So this was the pathogenesis of nephrotic syndrome. Now let's look into the major complication of nephrotic syndrome. I have mentioned the 3 major complications here. First, being coronary atherosclerosis. You can see that it is directly related to you can see that it is directly related to lipiduria. Second is infection, क्योंकि there is already loss of albumin and immunoglobulins in the urine. It will make our body prone to infections. Third being the thrombotic or thromboembolic complications. Now, what are the causes of nephrotic syndrome? The most common cause is diabetes mellitus, systemic lupus erythematosus, amyloidosis. These are the most common systemic causes. Now, primary disease cause is MCD, MGN, FSGN. What is this? Do you remember me teaching the classification of glomerulonephritis? उसको हम लोग प्राइमरी एंड सेकेंडरी में डिवाइड किए थे. एंड इन प्राइमरी वी हैड सीन दिस minimal change disease, membranous glomerulonephritis and focal segmental glomerulonephritis. Nephrotic syndrome के बाद we'll be looking into nephritic syndrome. It is a syndrome of disease characterized by hematuria, dysmorphic red cells, the red cell cast in urine, azotemia, oliguria, and mild to moderate hypertension. Some of the features here, it is actually common to a nephrotic syndrome, but there are many differences as well between nephrotic and nephritic syndrome. First we can see कि hematuria या nephritic syndrome से associated है, not with nephrotic. Same goes with dysmorphic red cells. Red cell cast in urine, ये भी nephrotic syndrome में present नहीं होता है. Azotemia, oliguria, all this. But if you look into proteinuria is mostly associated with nephrotic syndrome. यहाँ पे nephritic में we can see proteinuria but not massive. Certainly it can be mild or moderate. And hypertension, mild to moderate, is also associated with nephritic syndrome. The third of our disease is post-streptococcal glomerulonephritis. नाम से पता चल रहा है it is caused due to the infection by streptococcus, which can be like an initiator for the glomerulonephritis. Pathogenesis of this disease is that it follows streptococcal infection. It is an immunologically mediated disease. Mechanism: immune complex form होता है within the circulation जो कि glomerular में जाकर deposit हो जाता है. And this immune complex ये initiate करता है inflammation by activating the complement and other humoral and cellular mediator of inflammation. The immune complex, they are formed within the circulation. ये डिपॉजिट होता है ग्लोमेरुलाई में. Then these immune complex डिपॉजिट होने के बाद ये inflammatory reaction इनिशिएट करता है, जो कि इन्वॉल्व करता है एक्टिवेटिंग कॉम्प्लीमेंट एंड अदर ह्यूमरल एंड सेलुलर मेडिएटर्स. And now they attract and activate neutrophil and monocyte, which can further damage the glomeruli. The lab findings in these is that in blood you'll find high ASO, that is anti-streptolysin. In lab finding, first blood examination करने के बाद you'll find high ASO titer. ASO is anti-streptolysin O titer, जो कि streptococcal infection से associated है. There will be decrease in serum 3,3 level, increased blood urea and serum creatinine, which indicate renal impairment. Urinary finding, there will be oliguria, that is decrease in urine. There's decrease in urine secretion less than 400 ml is oliguria. Then there can be mild proteinuria. Hematuria, the urine will be smoky or cola colored. Please remember this cola colored urine. And in microscopy, you'll find red cell cast or dysmorphic red cells. This was all about streptococcal glomerulonephritis. I'll go through it once again. Follows the post-streptococcal infection. It is immunologically mediated disease. The mechanism is actually deposition of immune complex in the glomeruli, which further initiate inflammation by activating complement and other cell and humoral mediators, leading to activation of neutrophil and monocyte. Now the lab finding is increased ASO titer, decreased C3, and increase in blood urea and serum creatinine. Urinary findings can be oliguria, mild proteinuria, hematuria, and microscopy you'll see red cell cast as well as dysmorphic red cell. Moving to the next topic or the next disease, which is rapid progressive or crescentic glomerulonephritis. So it is also known as RPGN. It is a syndrome which is characterized by rapid progressive loss of renal function, which is associated with severe oliguria and sign of nephritic syndrome. So there will be a severe oliguria and all the signs जो कि अभी हमने nephritic syndrome में देखा है, they are also associated with this. The most common microscopic feature here is the presence of crescent in most of the glomeruli. Hence, it is also known as crescentic glomerulonephritis. So, जिस crescent के बारे में हम लोग बात कर रहे हैं, what are these actually? So, ये diagram एक जो मैंने यहाँ पे draw किया हुआ है, I'll explain through this diagram. This whole structure is actually a Bowman's capsule, और ये glomerular capillary है. These cells which are lining the Bowman's capsule, they actually start proliferating abnormally. सेल कुछ इस तरह से डिवाइड करते हैं कि जो शेप फॉर्म होता है, यू कैन सी एक सेमी ल्यूनर काइंड ऑफ शेप फॉर्म हो जाता है. कैन यू अप्रिशिएट दिस सेमी ल्यूनर शेप? द सेमी ल्यूनर शेप, कैन यू अप्रिशिएट द सेमी ल्यूनर शेप, जिसको अदरवाइज क्रेसेंट भी बोलते हैं. सो दिस इज एक्चुअली व्हाट क्रेसेंट इज. इट बट कॉम्पोनेंट्स क्या है क्रेसेंट में? द एपिथेलियल क्रेसेंट, जो कि प्रोलिफरेशन है पेरेंटल एपिथेलियल सेल का लाइनिंग द Bowman's capsule. They also have some of the fibrin, macrophage inside, and also you can find some monocytes जो कि infiltrate करता है इस क्रेसेंट को. Now what are the components? The component, it is epithelial crescent. It is formed by proliferation of parietal epithelial cell lining Bowman's capsule. There you can also find infiltrated monocyte macrophage in the urinary space. Crescent. So what is actually the stimulus of crescent formation? The fibrinogen which are found in the glomerular basement membrane, they get converted into the fibrin, and these fibrin they escape into the Bowman's capsule. Okay, obviously this already these glomerular basement membrane is ruptured. ये अलाउ करता है easy passage of fibrin. अब ये fibrin escape करके Bowman's capsule में आ चुका है, which is not normally found in Bowman's capsule. It can stimulate the formation of crescent. Now coming back to the rapid progressive glomerulonephritis, ये जो मेन माइक्रोस्कोपिक फीचर था क्रोसेंटिक ग्लोमेरुलोनेफ्राइटिस, ये तो हमने देख लिया. अदर माइक्रोस्कोपिक फीचर्स लाइक ट्यूब्यूल्स में रेड कास्ट, रेड सेल कास्ट, इंटरस्टिशियम में इडेमा, इन्फ्लेमेटरी सेल, these are also seen. And the glomeruli, the characteristic feature I've already told you, the crescent formation. These are the microscopic findings. अब इस डिजीज़ को हम लोग क्लासीफाई करते हैं इंटू टाइप 1, टाइप 2 एंड टाइप 3. टाइप 1 इज एंटी ग्लोमेरुलर बेसमेंट मेम्ब्रेन एंटीबॉडी फॉर्मेशन के कारण हो रहा है ये. गुड एग्जांपल इज गुड्स-पास्चर सिंड्रोम. टाइप 2 इज एक्चुअली इम्यून कॉम्प्लेक्स डिपोजिशन बेस्ड. इट कैन बी इडियोपैथिक और इट कैन बी PIGN or it can be lupus nephritis. Now, the type 3 is pauci-immune. It can be idiopathic, Wegener's granulomatosis, or it can be ANC associated. Now, let's move to Kurzbascher syndrome. The anti-glomerular basement membrane antibody, they cross-react with pulmonary alveolar basement membrane causing pulmonary hemorrhage associated with renal failure, which lead to the disease Kurzbasser syndrome. So what I actually said कि जो ग्लोमेरुलर बेसमेंट मेम्ब्रेन है उसके अगेंस्ट और उसके एंटीबॉडीज़ ये जो है जाकर के पल्मोनरी एल्वियोलाई के बेसमेंट मेम्ब्रेन के से जाके रिएक्ट कर लेता है और ये पल्मोनरी ऑब्वियसली देयर इज रिएक्शन गोइंग ऑन, कैपिलरीज रप्चर होगा एंड इट विल अल्टीमेटली लीड टू हेमरेज which is also associated with renal failure. What is the pathogenesis? First, it can be genetic predisposition, high prevalence of certain MLA subtypes. Then it can be anti-glomerular basement membrane antibodies. They are formed against Goodpasture antigen. Then these antibody they cross-react with target antigen. They are expressed on pulmonary alveolar capillary basement membrane, and it further leads to hemorrhage and hemoptysis. Microscopic findings अगर देखें तो there is also crescent formation. The components is formed by proliferation of parietal epithelial cell lining Bowman's capsule. I've already told you these things. Infiltration of monocyte macrophage into urinary space. Stimulus, I already told you. The significance is that it indicates severe glomerular injury. Now this was all about Kurzbasser syndrome. Moving to the third disease, that is membranous nephropathy. It is characterized by uniform diffuse thickening of glomerular capillary wall, which is due to accumulation of electron dense deposit along the subepithelial side of glomerular basement membrane. यहाँ पे भी थिकनिंग हो रहा है ग्लोमेरुलर कैपिलरी वॉल्स का, जो कि मोस्टली एसोसिएटेड होता है विद accumulation of electron dense deposit. And important point here to note is that it is along the subepithelial side of glomerular basement membrane. Now, etiology is very much same as the other nephropathy we have seen earlier, or glomerulonephritis we have seen earlier in RPGN and others. Now, let's see the pathogenesis. Pathogenesis you'll find quite similar only. It is a chronic immune-mediated disease. Can be idiopathic. Autoimmune disease caused by antibody which react with in situ or implanted or endogenous antibodies. They are most often directed to phospholipase A2 receptor antigen, which is PLA2R. Phospholipase A2 receptors, these are present on podocyte. उसके against directed होता है ये antibodies. So what I meant to say is that the antibodies, they are directed to the phospholipase A2 receptor antigen which are present on the podocyte. Now, in situ formation of immune complexes there. This was the idiopathic reason. Coming to the secondary reason, it can be circulating immune complex, exogenous or endogenous. Coming to the mechanism of glomerular injury, do you remember the site? As I told earlier, it is on the subepithelial site of the glomerular basement membrane. So there is formation of subepithelial immune deposit which activate complement system on podocyte. It generates C5bC9, which is the membrane attack complex, damaging the podocyte and mesangial cell, which liberate the protease and oxidase. further causing capillary wall injury and leakage of protein, which will lead to proteinuria. So this was the mechanism of glomerular injury. First, there is formation of subepithelial and immune deposits. Then there is complement system activation. C5b to C9 membrane attack complex form होता है जो कि podocyte and mesangial cell को damage करेगा. This will lead to release of enzymes like protease, oxidase. These are destructive enzymes. ये capillary wall को injure करेंगे and leakage of protein will happen. The clinical feature of this disease is onset of nephrotic syndrome. There is non-selective proteinuria, which means it can be albumin as well as globulin mostly, and there is no response to corticosteroid therapy. I was talking about membranous nephropathy. Please remember it is one of the important ones. Now let's move to minimal change disease. So it is named so because glomerular changes which is it is absent or minimal. जब भी हम लोग इस डिज़ीज़ में अफेक्टेड जो ग्लोमेरुलाई है उसको अगर हम लोग लाइट माइक्रोस्कोप के अंदर देखें तो दे ग्लोमेरुलस दे अपीयर वेरी मच नॉर्मल, या फिर अगर हम लोगों को कुछ एबनॉर्मेलिटी दिख भी रहा है या चेंजेस दिख भी रहा है, इट इज़ सो मिनिमल दैट वी कांट रियली अप्रिशिएट इट to that much of extent. That's why it is known as minimal change disease. Now the glomeruli, they appear light normal under light microscope, as I said, and under electron microscope the diffuse effacement or loss of food process of visceral epithelial cell, also known as podocyte, is seen. तो light microscope के अंदर तो you'll see no changes, but under electron microscope you'll see effacement or loss of visceral epithelial cells. The major cause of minimal change disease is nephrotic syndrome in children. Minimal change disease is the major cause of nephrotic syndrome in children. Let's look into the etiology and pathogenesis. Pathogenesis of this disease is quite unknown, but the etiology under electron microscope, what is seen is there is primary change in podocyte. It can be caused due to immunological mechanism or non-immunological mechanism. Non-immunological mechanism can also include mutation, namely in nephrin and podocyte protein of glomerulus. But though rare, this is actually very rare, but it can be seen. What are the changes which can be seen in light microscope? So as I told earlier, the glomeruli, they appear normal, but that doesn't mean the whole part is normal. The tubules, the cytoplasm of the epithelial cell which line the proximal tubule, they contain lipid vacuoles. Glassy or hyaline protein droplets can be seen, that's why it is also known as lipoid necrosis. So glomeruli में कोई change नहीं है, but PCT के epithelial के cytoplasm में you can see lipid vacuoles as well as glassy or hyaline protein droplets. In interstitium, there is mild edema and the blood vessels appear normal. What are the electron microscopic changes? The glomerular basement membrane is normal, but the podocyte, there is effacement of the food processes or the pedicles. The clinical features, it mostly present as nephrotic syndrome. It is one of the cause of nephrotic syndrome, so the clinical presentation is quite much same. So it may be preceded by its upper respiratory tract infection or immunization. It can be preceded by them. Then proteinuria is highly selective, that is albumin, is mostly albumin, followed by globulin. So this was all about this lecture, but ये chapter अभी ख़त्म हुआ नहीं है. Minimal change disease is one of the most common cause of nephrotic syndrome in children, so you must actually go through it again nicely, make notes and read about it again. इसके बाद हम लोग further आगे की disease like focal segmental glomerulonephritis and all will deal with those topics in second part of this video.